Pediatric cardiology is, well, it's basically a series of incredibly complex, high-stakes physiological puzzles. We're talking about situations where normal anatomy is just fundamentally altered, demanding some absolutely extraordinary interventions literally from day one of life. Just think about this quote for a second. Reconstructing a heart the size of a walnut requires absolute anatomical precision. The stakes here, they are absolute. We're talking about 1 millimeter being the literal difference between a thriving child and a failing circulation. Welcome to this continuous clinical challenge explainer, where we're going to run right through these scenarios. Okay, let's dive right into this with question 14. What is the definitive anatomical surgical repair of choice for complete transposition of the great arteries, usually done in the first 2 weeks of a neonate's life? Are we looking at A, the Senning procedure, B, the Mustard procedure, C, the Jeté arterial switch operation, or D, the Fontan procedure? Take a second. If you said C, the Jeté arterial switch operation, you hit the nail on the head. This procedure is just an absolute masterclass in surgical precision. To fix complete TGA anatomically, the surgeon literally has to transect both the aorta and the pulmonary artery and swap them to their correct ventricles. But honestly, the true drama here, it's the coronaries. Those tiny native coronary arteries have to be meticulously explanted from the old native aorta and translocated, perfectly intact, into the neo-aorta. That is the only way to preserve myocardial perfusion. Just incredible. Moving right along to question 15. Picture a 3-day-old neonate diagnosed with hypoplastic left heart syndrome, or HLHS. The left ventricle, the mitral valve, and the aortic arch are all severely underdeveloped. So what's the standard surgical strategy here? A single-staged open repair. B, a staged 3-stage palliative surgical pathway, C, non-operative management, or D, simple ligation of the IVC. The correct strategy is B. Now, what's really interesting about this slide is how the physiological journey unfolds, because that left ventricle is essentially non-functional. A true anatomical cure just isn't on the table. Instead, we rely on a 3-stage palliative pathway. The whole goal? Making the right ventricle the sole pump for the entire body. It kicks off with the Norwood procedure for the newborn, then the Glenn shunt around 4 to 6 months, and finally the Fontan procedure between 2 and 4 years old. Let's move to and see how this builds with question 16, looking closely at that first critical step, the Norwood procedure. To secure a systemic outflow tract, the correct approach is C. The surgeon divides the main pulmonary artery, anastomoses its proximal trunk to the tiny hypoplastic aorta to build a wide neo-aorta, performs a wide atrial septectomy so pulmonary venous return isn't hindered, and places a systemic to pulmonary shunt to secure blood flow to the lungs. Boom. In one single operation, the right ventricle becomes the main systemic pump. Next up, question 17. The infant comes back at 4 to 6 months for stage 2, connecting the superior vena cava directly to the right pulmonary artery. What's this called? That's option B, the bidirectional Glenn shunt. The hemodynamics here are fascinating. By routing the deoxygenated blood from the upper body straight into the lungs, bypassing the right atrium entirely, we drastically offload the volume workload on that single, massively overworked right ventricle. Bringing us to question 18. The final stage routes all the remaining systemic venous return from the inferior vena cava straight into the pulmonary arterial system. That's option C, the Fontan procedure. By connecting the IVC to the pulmonary artery, the systemic and pulmonary circulations are finally completely separated in series. The right side of the heart is bypassed entirely, leaving that single ventricle to pump exclusively oxygenated blood out to the body. Which leads us right into question 19. What is the principal physiologic requirement for a patient to actually tolerate this Fontan circulation? Are we looking for A, severe pulmonary hypertension, B, low PVR and preserved single ventricle function, C, severe tricuspid stenosis, or D, a continuous, high-volume right-to-left atrial shunt? Think about the mechanics of a totally pumpless pulmonary circuit. The answer is B. So the crucial point is this. A Fontan circulation doesn't have a dedicated ventricle to push blood through the lungs. Passive blood flow through the pulmonary bed relies completely, 100%, on central venous pressure. To survive, the patient absolutely must have extremely low pulmonary vascular resistance, PVR, and preserved excellent single ventricle function. If that PVR gets high, the passive flow system just fails, leading to catastrophic venous congestion. Let's shift gears to venous and atrial anomalies with question 20. We have a 1-year-old child presenting with recurrent pulmonary infections and mild cyanosis. An echo shows that all 4 pulmonary veins fail to connect to the left atrium. Instead, they're draining abnormally into a vertical vein that empties right into the SVC. What anomaly are we dealing with here? This classic presentation points to B, total anomalous pulmonary venous return, or TAPVR. Here, oxygenated blood from the lungs completely bypasses the left heart, draining right back into the systemic venous circulation. What this means is that the only way mixed blood can ever reach the left side of the heart, and therefore the rest of the body, is through an atrial septal defect. Without an ASD to act as a bypass mechanism, this condition is simply incompatible with life. It is literally their lifeline. Now, question 21 takes us right back to a delivery room emergency. Which anatomical subtype of TAPVR is most frequently associated with severe infradiaphragmatic obstruction and profound neonatal distress right at birth? Is it type 1, type 2, type 3, or type 4? It's option C, type 3, also known as infradiaphragmatic TAPVR. And here's why this is an immediate life or death scenario. The abnormal venous pathway actually loops downward, right through the diaphragm, to connect with the portal or hepatic veins. But when this conduit hits the high-resistance hepatic sinusoidal bed, it creates a massive mechanical choke point. That obstruction triggers immediate severe pulmonary venous congestion and profound cyanosis the second the baby is born. It demands emergent surgical correction. Jumping ahead to adolescence for question 22. A 14-year-old female presents with progressive dyspnea on exertion. Her physical exam reveals a fixed, widely split second heart sound and a mild systolic ejection murmur at the upper left sternal border. What is our most likely diagnosis from these options? That fixed, widely split S2? That points us straight to B, an atrial septal defect. Let's break down the physiology. The left or right shunt across that ASD increases the blood volume sitting in the right atrium and right ventricle. Because of that volume overload, it literally takes longer for the right ventricle to empty itself, which delays the closure of the pulmonic valve. And the reason it stays fixed during breathing is because that open atrial communication buffers the normal respiratory variations in venous return. Keeping the momentum going with question 23. Which specific ASD subtype is located at the lower portion of the atrial septum, right adjacent to the AV valves, and is classically associated with a cleft in the anterior leaflet of the mitral valve? We're talking about option B, the ostium primum defect. Because it's located way down at the base of the atrial septum, this is actually classified as a partial atrioventricular septal defect, or AVSD, stemming from a deficiency in the endocardial cushions. And that specific anatomical location is exactly why it's so tightly linked to AV valve anomalies, like that structural cleft in the mitral valve. That cleft severely predisposes the patient to significant mitral regurgitation down the line. All right, advancing the clinical timeline to adulthood with question 24. A 35-year-old male with an unrepaired defect develops progressive cyanosis, finger clubbing, and a massive elevated hematocrit of 62%. This secondary elevation in red blood cell mass is driven by the hypersecretion of which hormone? The answer is B, erythropoietin, or EPO. And this brilliantly illustrates a step-by-step physiological feedback loop. Chronic right-to-left shunting is constantly delivering deoxygenated blood out to the systemic circulation, causing chronic tissue hypoxia. The peritubular interstitial cells in the kidneys sense that low oxygen tension, and to protect the hypoxic brain and organs, they aggressively upregulate EPO. This basically orders the bone marrow to pump out way more red blood cells, resulting in that secondary polycythemia we see. Moving to question 25. A 6-year-old presents with stridor that actively worsens during feeding. Imaging shows a posterior esophageal indentation, and an MRI confirms a double aortic arch completely encircling the trachea and esophagus. How do we classify this anomaly? This mechanical squeeze is characteristic of B, a vascular ring. Notice that we've switched gears here. This is entirely a mechanical problem. It's not about abnormal blood mixing, it's strictly a plumbing and pressure issue. That abnormal arch development creates a ring that physically chokes the trachea and esophagus, causing the stridor and dysphagia. To fix it, you have to physically go in and surgically divide the non-dominant arch segment to relieve that pressure. Question 26 looks at one of the coolest things in cardiac surgery, the Ross procedure. A young adult needs a stenotic aortic valve replaced. The surgeon harvests the patient's own native pulmonic valve, moves it to the aortic position, and uses a homograft for the pulmonary side. Option C, the pulmonary autograft, is the correct answer. The ingenuity here is just awe-inspiring. By using the patient's own living, growing tissue, they get a permanent, living valve that handles systemic pressures without needing lifelong blood thinners. It's amazing. Which leaves us with this final thought. If a living pulmonary autograft can structurally adapt to systemic pressures over an entire lifetime, how do other acquired structural changes remodel the adult heart over time?